to Ethics for Lunch for April. My name is Mark Hughes. I'm co-chair of the Johns Hopkins Hospital Ethics Committee, and I want to welcome you to our monthly installment where we have an opportunity to discuss as a community ethical issues that are importing especially clinical medicine. So this is co-sponsored by both the Ethics Committee and the Berman Institute of Bioethics. On your handouts, you'll get information about both of those and the faculty and other members of the committee that are available as resources to you if that's ever of interest. To let you know that this is a CME or continuing education activity, so if you want to apply for credits or just have documentation that you've attended, there's a separate handout where you have to use your smartphones nowadays and plug in the code and a text message, and that will get you logged into the system to verify your attendance. That's really our only means nowadays of logging that, so if you're interested, please avail yourself of that. We've got a great panel today, an interesting topic, which I'll get to in a second. I wanted to alert you also that next week we have our annual Schallenberger lecture. So this is once a year sponsored by the Ethics Committee. The Berman Institute also co-sponsors. And this year we're having Howard Brody, a visiting lecturer, come talking about medicine, money, and power, electronic records, and scarcity of resources. So it's going to be next Tuesday at noon, so if you can come, please join us. I think we'll be across the way here in the auditorium. Today, we're going to be talking about responding to patients who make racist, sexist, or otherwise offensive comments. Our moderator for the session is Dr. Joseph Carrese. He is a professor of medicine. He's a core faculty member of the Berman Institute of Bioethics as well. He chairs the Ethics Committee over at Bayview Medical Center, and he was the originator of Ethics for Lunch. So he started it over at Bayview. We thought it was such a great idea, we decided to do it over here at Johns Hopkins Hospital. So I'll have Joe introduce the panel and get us started.
Okay, well, thanks for the introduction, Mark. Thanks very much. I'm going to briefly introduce the panel and then make some background remarks about the topic. So first is Dr. Durant, who has started her career in bedside nursing, has a doctorate in counseling, doctorate in divinity, and master's of education, and her current major role at the Bayview Medical Center is as an ancillary education specialist in the Department of Interprofessional Practice and Patient Safety. At the end of the table is Mr. James Page, who has an MBA. He's Vice President and Chief Diversity Officer for Johns Hopkins Medicine. He's been recently convening meetings on this very topic and working on system-wide policy related to this issue. So we're very much looking forward to his insights and guidance. And then in the middle, Dr. Thayer, who's a third-year internal medicine resident in the Bayview Internal Medicine Training Program. He can just about see the light at the end of the tunnel. At this point, he has a master's degree in health economics from the London School of Economics. So just to give a bit of background about my own sort of connection to this topic, I'm a graduate of the General Internal Medicine Training Program at Bayview decades ago. I've remained closely connected to the training program in a variety of ways. One of those ways is that I'm the faculty facilitator for a weekly forum where trainees come together over lunch without an agenda to talk about their experiences, what's going on in their work as a trainee at the hospital, what's going on in life more broadly defined. I'm meeting with the interns one week, and on the alternate week, the second and third year residents as a group. And about 10 years ago, on consecutive weeks, in each group, a house officer brought forward a story about this happening to them. A patient making a racist remark, a sexist remark. It happened the next week as well. And is often the case in this particular forum, when a trainee takes the risk of bringing forward an issue that they've been dealing with or struggling with, and share it with their colleagues, they learn that they're not the only person who's been experiencing this. And sadly, that was the case on both of these occasions, that a number of other trainees reported and talked about their own stories with this issue. So I felt the responsibility, with the permission of the trainees, because it's a confidential forum, to bring this forward to our department. We began working then about a decade ago on a program, departmental response to this issue. What do we as faculty need to know? How would we respond? How would we guide our trainees on this issue? So I'm going to be presenting that model today for discussion and input. I'll be probably talking mostly about trainees, because that's my point of orientation, graduate medical trainees, but certainly this patients who are racist or sexist don't limit their comments to interns or residents. This will affect nurses, aides, environmental services, anybody who they come into contact with. So I certainly want to acknowledge that and certainly fill in the blank as I go along in ways that are relevant to you. We felt that while this is always an important issue, given what's been going on in the national political climate, I think we've all seen more of this happening on the 2 campuses, and felt like this was a good time to bring this forward for a discussion at this forum. One other point of introduction is, of course, there's a literature on this topic. In the online message that went out announcing this, we listed 4 references, but there's a much larger literature than that if you're interested in reading more. One of the articles referenced was published in the New England Journal of Medicine about a year ago in February 2016. The title was Dealing with Racist Patients. The lead author, Kamani Paul Emily, who is a lawyer, presented, I believe, in this room in December in the Berman Institute seminar series. That was videotaped and is available online, so if you search, and even I could do this, so if you put in the search term Kamani, K-I-M-A-N-I, Berman on YouTube, and search, it'll come up, and I think it's a very good talk worth looking at. So here's our proposal for what we do for the next 40 minutes or so. Briefly identify the problem, share with you our proposed learning objectives for the session. Then I'm going to invite Dr. Thayer and Durant to share some of their own personal experiences with this issue. I'll then present the model that we've been using at Bayview to try to address this. And then we'll invite comments from Mr. Page. And then hopefully with the 15 to 20 minutes left, we'll open this up for a dialogue, question-answer discussion between the audience and the panelists. Basically, the problem is patients who make racist, sexist, derogatory, or otherwise abusive or offensive comments, or engage in similar behaviors that are directed at trainees, staff, faculty, anyone who they come into contact with. The objectives for today are to increase awareness about this problem, and then review and discuss the ethics and professionalism considerations that might inform specific strategies for responding to and managing these patients and the situations that they create. And then more broadly, just consider what role each of us might play when patients make abusive or hateful comments, regardless of our particular roles and responsibilities. So what I wanted to do now was invite first Dr. Thayer to share his own experience with patients who are commenting like this, acting like this, and tell us about that.
Thank you, Dr. Cruz. So I have one story that I want to share, and then a bit more in addition to that. So my story is from the start of intern years. This is July, August 2014. Taking care of a patient. Sure. Okay. Taking care of a patient, he asked me what my last name was, followed by what my first name was. Asked me where I used to work before I worked as a doctor at Hopkins Bayview. Told him I worked in England. Where were you before that? Where are you really from? Said I'm from Pakistan originally. He frowned and said, so you're a terrorist. So it was like right out of the gate. No Socrates, really abrupt. I was taken aback, but I smiled. I didn't respond. Told him what I had to tell him about the plan, walked out. Did not tell anyone in the nursing staff, my co-interns, residents attending. Though it was unfortunate that this happened, I wasn't quite sure how to respond in the moment, what kind of support was present at the time, and I assumed that this was a one-off event, and maybe this cannot be generalized. So my process at the time was just to sort of suppress this incident, talk about it, and hopefully we can move on, so to speak. But in the background of all of this, I've observed a lot of microaggressions, as they're called. What I mean by that is when people find out where you're from, what your ethnicity is, what your race is, they sometimes can change their tone. You see a lot of nonverbal cues, and a lot of times your discussions become a bit brief as well. So the challenge that I have in sort of facing patients like that is it because I'm hypersensitive or have become hypersensitive as a consequence of that one event? Or is this truly behavior that's undesirable? But I think because I had all these microaggressions in the background of a event that I explained to you, I think that played on my mind quite a lot. And I hadn't told anyone about it. Eventually, towards the second year of intern year, I had thought of not being in the program anymore, primarily because of this reason. So I said, quality of life is horrible. I'm an intern. All this is happening. I was pretty comfortable in my previous job. I applied for jobs as well, and I got offers as well. But eventually, I think things just fizzled out. I got married, developed a bit more social support, and I think the microaggressions somehow became a bit more acceptable, so to speak. They weren't right, but it didn't bother me as much because I had good social support around. I know Dr. Carrese will talk a bit more about what we do at Hopkins Bayview in terms of new conferences, but I did not share this incident with him for a year and a half. I think the biggest part of that was I felt that people may not be able to relate to what I'm going through. That was the biggest reason. Even if, say, hypothetically, at that point in time, if I would have told someone, they would have felt sorry, they would have said, yeah, it's unfortunate, and maybe would have told something to the patient about how would have solved issues at the micro level or at the macro level. So that's why.
So I think we'll have the opportunity to ask Dr. Thayer some follow-up questions during the discussion. I'm going to ask Dr. Durant to share her experience.
Hi, my name is Ella, and like previous speaker, no one has to ask. You can see straight up I'm black. I'm African American, and that offends a lot of people. So I'm going to use 3 brief scenarios. The first is years ago when Mr. Ronald Peterson was president of Hopkins Bayview. He came into my office one day and he said, there's a lady in the lobby using all kind of foul, racist remarks, but yet she's insisting on seeing Ella Durant. He said, how do you handle that? So I said, my usual self, I let them come in, I let them vent for 3 or 4 minutes or however long I feel like I want to tolerate it. And I say, well, now that you've made it known that you don't like black people, let me make it clear, you're not on the top of my list either. Now, how may I help you on behalf of this hospital? And so we get along after that. I allow this event, they have a right not to like black people, okay? But how may I help you on behalf of the hospital? My motto is, let your professionalism override your prejudice. So I'm always as pleasant as I can be, acknowledging that you don't necessarily like me, but I'm not here for that. Okay, so that was one scenario. Another scenario, this is when I was at the bedside, so years ago when I looked a lot younger and a lot better. When you walk into the room and there were male patients, they would say things like, hey, baby, you look awfully good today, and things like that. So you have to maintain your professionalism. Say, my name is Ella Durant, and I'm going to help you today. Okay? Go in again, and they say the same thing. Say, oh, you've forgotten my name. I see you've forgotten my name. So I'm going to call you Mr. Jones, and you can call me recovery and discharge, because that's what I'm going to be moving you to. So people bring you hardship and things of that nature, but it's up to us as to how we take it and how we respond to it. The third one was a patient. He was on the medicine unit and giving everybody, doctors, nurses, everybody a hard time because he felt everyone was stupid. So I was asking him, well, to see what you can do. Well, as soon as I hit the door, I'm glad that he knows I'm stupid. So I go in and I said, hi, how are you today? My name is Ella. And right off the bat, before he just said hello, he said, do you know why the toilet seat was invented? I'm not going to prove I'm stupid, I just admit. I said, no, I don't. I've never given it any thought. However, if you know something about it, can you share it with me? So he proceeded to tell me that back in the 1800s, there was this epidemic of hysteria. Is that the right word? Yeah, I mean, you know, excessive dysentery. Thank you. And so he said it was found that if when people flushed the toilet, there was something to cover it, to keep the germs from getting out into the environment, it would cut down on this dysentery. So, and apparently it did, because the epidemic soon left. So the fact that I listened and the fact that I admitted I didn't know anything about it gave him a chance to say that he was a retired judge and how the people there just didn't seem to be able to converse on his level. You know, he just needed a little stroking. So the fact that I didn't know anything about the toilet seat pleased him, and the fact that I wanted to listen. So it helped the hospital, it helped the doctors and nurses to do their job because it took the edge off a little bit from the patient. So I take every opportunity to teach whenever I can. So I feel like I'm doing my job toward the patient, toward humanity in general, by real nicely letting them know I accept your view, but this is mine.
And can I just ask a brief follow-up question to you, Dr. Grant? Dr. Thayer mentioned that it was really a year and a half before he shared what was going on with him, with anyone. As these situations occurred for you over the years, was it part of the culture or your work environment where you would talk to your nursing colleagues or other people you were working with about what was going on and compare notes, or is this something you typically handle by yourself?
Both. Once again, as an African American, I have dealt with this all my life, so it's a little easier for me to deal with than someone who is recently feeling prejudice. Prejudice is only felt when it's pointed directly at you, but once you have been the recipient, you are more aware of what's happening around you and what's being said to other people. So I am a firm believer in documentation and sharing of information, because if something happens along those lines to you, you share it and document it. It goes in a public record, or goes public, that this patient or this group of people are not really accepting of the society we live in. So the next person coming behind me can look and see, oh, this patient is a very negative person. I have to gear myself up before I walk into that room. And if this happens to someone else over and over again with the same patient or same group of people, it's documented that this is not an incidental remark. This is a behavior. This is their personality, and people need to make others aware of that. And once people realize that you don't accept those type things, they somehow get better with you, believe it or not. And it's not just confined to the hospital bed. I was in a grocery store once, and I was about the sixth person in line. There was a young Hispanic woman at the cash register. Well, she was the customer, and very obviously pregnant, about 9 months pregnant. She had a 5-year-old little boy with her. The cashier was giving her such a hard time, she began to cry. And it was all over a block of cheese, and I couldn't figure out what this cheese had to do with it. But the young woman didn't speak English well, and the more upset she became, the less likely she was to be able to speak English. So I said, excuse me, and the other customers let me up. And I said to the cashier, what seems to be the problem? Okay, she has this 8-ounce block of cheese, and she knows she's supposed to get 2 4-ounce blocks. She had some kind of a little card that paid for the food. So she, at that point, was sort of upset. So the little child, I assumed he could speak English. And I kind of began to talk to him. He translated for his mother. She went and got the 2 blocks of cheese. So I said, excuse me, got back at number 6 spot, not to cause me problem. So when I got to the cashier, she said, now what did you have to do with that? They go to a half-day's class to learn how to use this. And I said, well, what I had to do with it was totally wrong. And maybe the person that was teaching the class had the same attitude you did, so she wasn't able to catch up with it. So I turned around to the man behind me, who happened to be a white guy, and I said, when she begins to use the N-word thing, please say something kind about me when I leave. It's just who I am.
All right. So thank you to both of you. It really takes, I think, a fair amount of courage to come to an open forum like this and share personal stories, particularly if they're difficult. And I thank you for being willing to do that. What I'm going to do in the next 10 minutes or so is share the approach that we've been taking at Baby to try to address this problem in our training program. And the first step is just awareness, making in particular faculty aware that this is going on, faculty who may be in a position not to know about it. And then trying to figure out the appropriate way to respond. And I'm going to go in turn through the different levels of response at the individual level. If you're a team leader, like a faculty attending, or maybe a charge nurse, what about the program, the training program, or the unit that you work on, department, and institution. And I come at this from the perspective of ethics and professionalism, and Dr. Durant mentioned professionalism. So that I think that's the starting point for me as well. Always be a professional. Patients should be treated with respect and dignity all the time. And as a part of that, doing our best to embody the virtues of tolerance and empathy, understanding and compassion, courteousness. But there's a limit to what is acceptable, both ethically and in terms of our clinical interactions, and what should be tolerated. And it's our view that it is ethically permissible to confront disrespectful and offensive patient comments and behavior, and just let them know very clear that this is not acceptable. All of the articles that have been referenced as part of the online announcements support that view, as do other articles in the literature. I think it's worth pointing out that in our own the Patient Bill of Rights for this hospital and for the Baby campus include explicit language that's identical for each policy as follows regarding this. This is for patients, your responsibilities. You are expected to treat all hospital staff, other patients and visitors with courtesy and respect. So we make that clear in our policies, and it should be part of our ethical and professional expectations as well. So what about the individual response to this? So we encourage our trainees and we encourage our faculty to respond in some fashion. For the trainees, I guess the caveat would be if they feel comfortable and prepared to do so. We certainly don't want to force someone to interact with a disrespectful, racist patient if they don't feel comfortable doing that. But we certainly want to let them know they have the option to do that, and it's ethically permissible to do that. And then, encouraging them to talk with others, to involve others, members of their immediate team. So if you're an intern, talking with a resident or your co-intern, talking with your attending, sharing what happened, seeking advice, seeking support. I think the tendency, as Dr. Thayer mentioned, not that uncommon to sort of deal with this in isolation, and not, I think it's like just an issue for you, not feeling comfortable bringing it forward to anyone else. And so part of the message we're trying to get across to our faculty and our trainees is, connect with others, share with others, allow this to be part of a conversation with others. In terms of how our experience over the years in hearing about this in educational forums is that patients can respond to this at least one of three ways. So on some occasions, patients will stop their comments and their language and actually apologize. That doesn't happen, super frequently, but it happens on occasion. Others will stop the comments but not apologize. And of course, people who have been this way for decades aren't likely to turn on a dime, so others will continue with their comments and offensive behavior. Maybe in the discussion period, we can talk about your suggestions or ways that we've come up for exactly what to say. What are the things you would say to patients at the bedside when you're telling them that what they just said to you is unacceptable? In terms of the team leader response, and in my case, this is what we try to communicate to faculty members, certainly making sure they're aware of this. If their life experience has been such that this hasn't happened to them, they need to know that it is happening to other people, and it's happening to people that they're responsible for and supervising. So be aware, support your trainees and staff, colleagues that you're working with, and be supportive in ways that the trainees would understand as being supportive. So that doesn't mean forcing them to confront a patient when they don't feel comfortable. It doesn't mean speaking for them if they feel comfortable to be the ones who confront the patient. It means figuring out for this particular trainee, what do they want, how can you support them, what's the right way to go about it. So tailoring your response based on the circumstances. Certainly role modeling appropriate communication with the patient. So we've heard from our house staff that some attendings model an attitude of turn the other cheek, let this roll off your back. Your primary role, this is a service profession, you're supposed to at all times subordinate your needs and your interests to those of the patient. We would say from an ethics point of view, or I would, that there are limits to that, and this is one of those limits. And that when faculty model turn the other cheek, that doesn't feel especially helpful to people who, the trainees who've been verbally attacked by their patients. So it sort of leaves the trainee in the lurch. Sometimes, if the house officer doesn't feel comfortable or prepared, the attending has to be the one to step in. They should only do that if we sort of get the go-ahead from the trainee to do that, but they need to be prepared to know what to say and how to say it to patients who are saying these things. We think team leaders should be prepared to discuss and debrief these situations with the team, to make it a dialogue, to make it okay to talk about, to foster dialogue and support, and to view these episodes as teaching opportunities. Again, I think that the forum, Ali, where you brought this up, was at an ethics morning report session, and we were reading an article that had been in the Annals of Internal Medicine called The Nazi Patient. And am I remembering that right? And so we were having a conversation about this general topic, and people were telling stories, and you spoke up and talked about your story. So creating circumstances where these stories can come forward. The other thing I wanted to say about saying something is, we're in a situation at Bayview where most of the rooms are shared rooms, and if your temptation is not to say anything at all to a patient who makes these sorts of hateful comments, in addition to letting them know that that's not okay, another reason for saying something is that other people are within earshot. And we don't want people at Bayview to think that it's okay to be saying those things to the people who work there, people who are trying to take care of them, that it's a culture where that sort of attitude is acceptable. So in addition to all the other reasons for saying something, that's another thing to consider. So that would be the case for people, for example, who do not have adequate decision-making capacity, who have cognitive impairment and may not be in control of what they're saying. You might give them a pass. That's a reason to still say something, in addition to redirecting them or letting them know at some level that it's not okay, even if that's not going to change, because they can't sort of synthesize the information. Other people might be around who might be heard. In terms of the program of response, in our case, the internal medicine training program, we have established a position of no tolerance. If it's very clear that what's being said is bigotry and prejudice and shouldn't be tolerated, we don't tolerate it. So that can proceed up to and include administrative discharge of patients who don't modify their behavior. We take a position in front of supporting our frontline providers, whether it be nurses or interns, residents, medical students. Along those lines, we also will not accommodate requests for I want a different doctor if it's very clear that that is based on bigotry. I know that this is a complicated, the issue of accommodating patient requests for different providers, and maybe Mr. Page will comment on this, is a complicated area. But if it's, our view is it's not often that difficult to distinguish when this is based on bigotry and you don't accommodate that. If it's a Muslim woman who doesn't want to be examined by a male doctor, so it's a long-standing, deeply held culturally and religious-based value, of course, we would be support for accommodating that. So I think, you know, there are examples at each end of the continuum. There's a lot that are in the gray area. Maybe we can talk about some of those during the discussion. We certainly want the program and the unit to foster a culture of awareness and dialogue, and look for opportunities to train faculty and trainees about this. So forums like this, our own Ethics for Lunch forum in Bayview, we have an ethics morning report session where we will address this, and we talk about it periodically at our Department of Medicine faculty meetings. Certainly, the issue of administrative discharge would have to take into consideration, you know, extenuating circumstances like a patient who's hemodynamically unstable, so not in a position to be transferred or discharged, or if you're the provider of last resort, or if there's some, you know, major issue with cognitive impairment or mental illness. So clinical medicine is complicated. You need to take those variables into consideration, but all other things being equal, that is an option. And in terms of the institutional response, we feel like it's important to think about ways in which we can more clearly communicate to our patients and the community of patients that we're responsible for what their responsibilities and conduct should be. I mentioned that we have policies, and Patients' Bill of Rights and Responsibilities articulates this, but you know, Dr. Durant and I were talking before this started, it's not likely that most patients who are being admitted to the hospital are carefully scrutinizing those policies. So what are other strategies for communicating with patients, letting them know? And beyond the walls of the hospital, you know, should we be making some efforts to do this into the community through outreach and education? So those that's what we're doing at Bayview. I'd be really interested to hear what folks think about that, what suggestions you have for modifying what you're doing, or whether you agree with it. Next, we'd like to hear from Mr. Page and sort of his general reaction to what's been said so far, and his thoughts about this topic and what's going on sort of in the system as well.
I'll have a video if you don't mind. So,
I definitely can't help you with that. But maybe somebody.
somewhat savvy.
Okay, good.
So, while that's being pulled up, one of the things that I really want to stress is this idea that our culture is probably our biggest defense against this kind of behavior. As we think about being at Hopkins, the wonderful thing about being at Hopkins is that we're from a place that is founded on roots that are opposite a lot of these behaviors. Now, unfortunately, right now we're at a time in our country where a lot of people feel empowered to behave in ways that are completely inappropriate, and up until this past several months, I don't think would have openly behaved in the ways that they're behaving. And also one of the things that I want to make clear is that this is not just limited to our two academic hospitals as well. I've spent time at our community hospitals and with our community physician practices, and we are seeing this same kind of behavior within those environments as well. So these idea of patients who are boldly making their requests made to be inappropriate and racist is something that spans our organization and impacts our students as well as our janitorial staff, our nurses, everyone. And there's also something we really need to keep in mind. There is a certain amount of power that a physician has to directly deal with these situations as well as a nurse. I do get very concerned about the experiences that you all have, but also I get equally as concerned about people who have limited power within our organizations who must deal with this on a daily basis, like the individuals that come in from environmental services or food services and feel that they must just bear this particular behavior. So there's a couple of things that we're working on right now. In my previous organization, we dealt with this a whole lot. And one of the things that we decided to do was create patient orientation videos that were electronically sent to patients as they entered the organization. And this explained to them the kind of environment that they were coming into, but not only that, the different roles that existed, whether they were pharmacy, nursing, or physician, residents, attending, student, et cetera, and how each of these roles were incredibly critical to the ability to provide an extraordinary experience to that individual. So these were emailed out, and they were also emailed out and sent out in 10 different languages. So they were not just limited to English-speaking individuals. We're working on those right now within Johns Hopkins to see if we can create those same kind of expectation videos. And in those expectation videos, we touched on things such as, I know it sounds ridiculous, but we asked the staff, what are some of the big issues you were dealing with? And they told us patients who throw stuff on the ground and just expect someone that's going to clean up after them. Patients who curse in the hallways or who physically discipline their children. Patients and families who have sexual intercourse in the patient rooms. Individuals that attempt to bribe staff members after they perform in an inappropriate way. So we actually included all of these behaviors in these orientation videos and said very clearly that these are not permitted behaviors within our organization. Just going to quickly show you a video. And this is a video that we're going to use here at Hopkins. It's still under development. We still have several tweaks to make to it, but I think it's important because it goes back to our roots. And the great thing about our organization, just a real quick history, is that Mr. Hopkins and his family decided in the early 1800s to emancipate, to set free all the slaves that they had on the tobacco farm. Now when they did this left the family in poverty, and Mr. Hopkins had to drop out of school to work the tobacco farms. And his roots as a Quaker are really important to who he is. So this kind of diversity DNA is in our leadership. If you look at the obituary from Mr. Johns Hopkins, it stated in his obituary in 1870 that he advised off forms of sectarianism and bigotry. This is in 1870s that this took place. Further, if we keep moving forward and you look at the articles that actually helped us form this hospital here that we're standing in, he stated that this hospital would not only be for whites, but also for sick, poor, colored people, and for children. Now, some people may be offended by the term colored people, but given that this was 125 years ago, I think there are a lot of other terms that could have been used that are a lot worse than colored folks. In addition to that, if you look at some of the dedications that Mr. Hopkins himself made, he decided that he was going to give out of his pocket $20,000 a year to fund a colored orphanage for the kiddos here in the Baltimore area. If you translate that in today's term, we're talking about a little bit over $5 million a year that he gave out of his pocket to fund this work. Now I'm going to show you the video. I want you to take a look at it, and it really does, I think, help set the stage for the kind of organization that we're a part of here at Hopkins.
To move forward, we must understand where we've been.
Our legacy can be traced back to a letter written by Mr. Johns Hopkins.
In 1873, he shared his vision with the Board of Trustees.
For a hospital that will be inclusive and a model of compassion for generations to come.
Today, we return to his core message.
We endorse his dream because we believe.
We believe in the values that he stood for: compassion, honor, equality.
I have given you 13 acres of land upon which I desire you to erect a hospital.
Nearly 50 years before the Emancipation Proclamation, the family of Baltimore philanthropist Johns Hopkins stood for human rights at great personal loss.
That the plan thus chosen the indigent sick of the city without regard to sex, age, or color.
We stand for inclusion, diversity, charity.
And the poor who are stricken down shall be received with
without charge.
Johns Hopkins was one of the first hospitals to open its doors to African Americans with a promise to provide care regardless of ability to pay.
To secure surgeons and physicians of the highest character and greatest skill.
We value dignity, perseverance, opportunity.
To establish a training school for female nurses.
Ours was the first major medical school to admit women on an equal basis as men.
To be so laid out and planted with trees as to afford solace to the sick and be an ornament to the section of the city.
His words inspire us today. They give us our direction.
The institution shall ultimately form a part of the medical school to make this charity a substantial benefit to the community.
A century and a half later, we are still here. We are still doing what's right. We are Hopkins. I am, very respectfully, your friend, Johns Hopkins.
Marunam Azmina Rahmanjuchin.
Ja, jullie van Turf.
Anna Imtisal Kesarwan.
I am Sushil Maharza.
Melinda Thomas.
Bia Hill. Ariel Barrow Cook.
So we still have a bit of work to do to this video, but I think it's a powerful video in that it gets us back to our roots. So when people come into our organization, we're not just talking about a newly adapted stance. This is who we are. This is what we were founded on. And when people come into our organization that feels that they should treat someone different because they are a young female, because they don't speak English as their first language, because they're African American, because they wear a burqa or a hijab, because their ancestors were not didn't voluntarily immigrate to this country. We say no, that's not who we are. And what's interesting about leveraging Mr. Johns Hopkins' words is that we are at a position where we can pretty firmly say that if you don't agree with the words of Mr. Hopkins, whether you're an employee or a guest or a visitor or a family, we may have to ask if this is the right institution for you to be inside of. Now, I know that's a tough thing because a lot of folks see this push and pull between patient-centered care and us being able to say that is not acceptable behavior, to see those as juxtaposing forces. But what I would say is the idea of dignity and respect and honor and pride goes both ways. It is not just simply limited to a patient's experience, but it's also something that every employee of this organization should feel empowered to do. And if that means that we need to call some folks in or empower you to say to someone, are you sure that you're going to say that you don't want this person in here because they are black or Muslim or women or whatever have you? Give the person an opportunity to reconsider what they're saying. And then we will find someone from admissions to help them start a discharge process that will allow them to go to an institution where they can behave in whatever hungry way they want. But it will not be, and I keep looking at Maggie to make sure I'm not saying anything inappropriate. Our lawyer in the corner. But it's one of those things where we should feel empowered that if someone cannot, in their right mind, cannot treat you all with dignity and respect, with honor, that we may have to ask them to make a recommendation on which institution they want to be a part of, because it probably is not going to be this one. So I'll just stop there if you don't mind.
So thank you very much, Mr. Page. So I guess we can open it up now for dialogue and questions and answers. Peter has a microphone. One thing I just wanted to clarify, when I said that our training program has a no tolerance policy for patients making these comments to our trainees, and in terms of the issue of them switching providers, so one exception to that would be if the trainee themselves doesn't want to stay in that situation and be continually barraged by that. So certainly that's an exception, but it would be just because of the patient wants.
Our panelists, but I wanted just to make a comment to Mr. Page that after 27 years of being here, that baby doesn't have that video is long overdue and probably should be broadcast across the world.
on a rollout plan for that video right now. It still has some tweaks that we need to make to it, but thank you so much for your comments. Hopefully you'll see an intentional rollout of that very soon, where we can start talking about who we are and why.
Just a question, is the video for new employees, and what do we do with our coworkers that may need to see that video?
I think we should just drag them by the collar and force them to join this thing. We are going to be starting you all saw the scroll that was signed, and that was those were the words of Mr. Johns Hopkins, in case you didn't realize it. We're going to be starting a campaign as part of the rollout. We're doing new employee orientation. People are going to get the opportunity to pin their name to that letter, and we're also going to have a campaign for existing employees where we're going to roll out several versions of this video, this scroll, and give employees and different members of our community the ability to pin their name and say, I agree with Mr. Hopkins and what he envisioned.
So I'd just like to say thank you to the panelists. But I noticed that in some of the examples, there seemed to be a degree of sarcasm in how you address the aggressors, and I'm just wondering if the sarcasm is really constructive, or or if it really reflects the dignity of the person who may have these racist attitudes.
So, just quickly, I dealt with this exact situation in a previous hospital, and the patient and family came in and said that the 4-year-old child did not want any dark-skinned individuals in their room. It's a 4-year-old child. Honestly, I didn't know exactly what that meant, but the mom further clarified that the 4-year-old child was okay with dark-skinned people as long as they were bringing in trays and food and cleaning and things of that nature. So we got with, at that point I got with our folks in patient relations, and we had a conference with the mom. And in a non-sarcastic way, we said we gave mom the opportunity to explain herself. She said the 4-year-old child feels this way. We said in a very serious way that, and it wasn't me. The great thing about it is that as the diversity officer, it was someone else that listened and encompassed these words. They said, we understand that you can get this kind of treatment at Akron Children's Hospital, but you will never be able to receive that treatment at our hospital. And mom explained it again, and she just reiterated. We understand you can get that in Akron, but you will not be able to get that at this current institution. And the mom said it one more time, and the woman with patient relations said, we will help you transfer to that hospital, but you will not be able to get that kind of treatment here at our organization. So I think while in this room is such a serious topic, there may be some levity, but when I deal with this, there is no levity in the room when I'm dealing with this situation, quite honestly.
Okay, I'd like to say that years ago, we did not have offices of diversity. So the person who was on the receiving end of the bigotry, the racism, the hate, you had to deal with it the way you could without beginning a fist fight with the person you're responsible for serving. So you had to respond in such a way that the person would get the message, and you kept it moving as to what you were there for. So once again, unless the prejudice is pointed at you, you don't feel it or don't know how you will respond personally. And my suggestion to everybody is to do some self-inspection. Everybody has a certain degree of bigotry about them, and that's based on our heritage, the experiences our people went through, and things of that nature. So in order to sometimes maintain your own professionalism, dignity, and sense of I can continue to do this job, you have to respond in the moment in the best way that you can.
I will also say that the role of the bystander is critically important in this. It should not always be the responsibility of the person who is being attacked to say, you can't treat me this way, especially given some of the power dysdynamics, the power inequities that exist within an academic medical center. I think it is really important that the straight white male feels an obligation to step in and say, again, where appropriate without taking power away from the other individual, to say that this is not appropriate behavior. And it's not always up to the victim to step in and to say that, that you can't treat me in this manner. So, and that also includes outside of the bedroom. We've had incidents in, unfortunately, at our institutions where people have been followed through the hallways, onto elevators, across campuses, and have told that you are going to have to leave our country because of whatever demographic you have, and they just had to endure it. And this was in a room with other people. So without creating danger for yourself, I think the role of a bystander is really, really important. And it also sends a critical message to the person who is on the receiving end of that there is someone else that is looking out for me.
And if I could just add on to that, we've heard from the trainees on the Bayview campus that when their attendings do that on their behalf, it's greatly appreciated, and they really feel supported. And it really sort of is the right way to handle it, rather than you attending, a model with some other alternative like attorney other chief.
And when these situations arise, if we don't speak up, anything you don't address, you condone. And if we allow this to continue to happen, it says we don't care that it's happening, and you can do this here. So I too am very grateful for that video.
Can I just add something about it, please? I was just sort of reflecting back on my approach to the situation that I mentioned earlier, on why I did not engage with the patient. I could not have had a philosophical discussion with him in that sort of brief moment. He was angry. And I was concerned also that if I were to talk to him, I may not be as professional as one would want to be. So for me, best course of action in the moment was to step out. So I think that's, in my opinion, reasonable. I think the fault that I had was not engaging with other people, but it happened. So what I'm trying to get at is, and I mentioned previously that I didn't sort of talk about it in the new conferences because I didn't feel people sort of relate to it, but I think going forward, other places like, for example, Hopkins, if you do adopt this model, I think it's reasonable to mention that these are the kind of instances that house staff or other people have brought up. So if everyone is experiencing that kind of situation, they know, okay, this is kind of okay. We've talked about it before, so it's okay for me to talk about it as well. I think that's a big part of it as well.
Normally.
Correct.
I have a comment, sort of a question, following up on this notion that what we don't, that we condone things when we don't speak up. I think it's important for us to recognize that our patients and our coworkers sometimes always, or sometimes feel a sense of underlying racism in our own behavior. And I want to address it because I think it matters. And I want us to make sure that we're talking about both sides of this story. Several years ago, I had an experience where I got on an elevator. There was an African-American gentleman on the elevator. And just before the doors, and nobody else, and just before the doors closed, I realized I left my stethoscope in the clinic. So I moved to get off the elevator to go retrieve my stethoscope. And he said, he accused me of being racist and being afraid to be on the elevator with him because he was African American. And I realized I had to say something. I stopped and I held the elevator door open and I said, you know what? That's just not fair. I forgot something and have to go get it. I'm not afraid of you or of this place, and it has nothing to do with the color of your skin or your gender. I just forgot my stethoscope. And it felt to me like I think we need to be very sensitive and aware of our own patients being afraid that we also are racist or that are treating them differently because of their skin color or their background or their cultural origin. So I want to make sure that we're talking about both sides of this, because I think it's a really robust conversation. I really admired the comments today. Just want to make sure we're not taking this in one direction only, because I think we need to really open it in both ways.
So I will say that one of the things I really admire about what you did is that you discuss the issue at hand. That's one of the things that usually people will not discuss. As an African American male, 6 foot tall, mocha chocolate, very white sounding African American male, there have been situations where I know people have avoided me because of what I am, without necessarily knowing who I am. Especially when I'm not here at work, I don't wear a shirt and tie. I wear one enough that I really look forward to not wearing. But also, one of the things that we need to keep in mind is that our environment at a hospital is one that creates tension overall. If you think about this environment, we use very complex language. People may not speak English as their first language, and if you think about the experience of going into a hospital, you get to a hospital, depending on how you get here, you may get here in a vehicle that has shiny lights and makes a lot of noise and can run red lights, and depending on where and when you come, you may have to come to an emergency department where you go through a metal detector, and depending on what's going on, you're probably going to end up with a patient identification number that's going to be the way that you're going to be referred to, and you're going to be given a space that you can stay while you're in this institution. You're going to be given special clothes to wear. They're going to take your clothes and pack them up and say, we're going to keep them until it's time for you to leave. We're going to tell you, here's a time when you can have visitors. Here's a time when you can eat. Here's a time when you can go to the bathroom. Here's the, again, the estimated date that you'll leave. And if you think about that particular environment, there's only one other environment in this country that has that kind of control over folks. And what happens is that unconsciously, people start to create links that puts them on edge. And when they come to our environment, they're already at an 8 or 9 as far as their level of tension. And so anything can spark it. And that's one of the reasons that I really like what you're saying about it is very appropriate to remove yourself from the situation if you feel that it is going to be too much for you to handle it in a professional manner.
I just asked you to comment, Mr. Page, on one of the meetings you convened that I was at. You had the safety director for the system, and one other, I guess another reason to not engage somebody is if you're worried about safety issues.
Absolutely, yeah, and so if one of these situations happen to you, especially if you're outside of a clinical environment, we've kind of started to lay out the ways that you respond. And one of the things that we're saying is that pay attention to where you're at, who the person is, and remove yourself and or your patient and the family from the situation. Don't create an unsafe environment by feeling that you must address something that could escalate quickly. After you remove yourself from the situation, you're paying attention to where things are happening, go find an officer and tell that officer exactly what happened, where it happened, who's the person that was involved. And then at that point, after you've done those things, start some patient recovery as far as experience recovery work. But we pretty much need to make sure that we all are safe, because sometimes when people behave in these manners, they are looking for a fight. And we are not a place where we're going to provoke that. We need to make sure that it is an appropriate environment and we get the right people involved so that everyone is safe.
How are we doing on time, Mark? We just... Okay. Can I ask, are there any other questions?
I was just curious as to whether you've seen over the years changes in, my question is whether you've seen over the years, and I think I'm probably thinking especially of Ella, changes in patient culture and how patients tend to react to it, and in your specific instance, African American staff and healthcare practitioners.
I really think that in the 80s, things got a little better. Over the last, I want to say 3 to 5 years, we have regressed. And particularly over the last few months, people feel empowered, even fashionable, to lash out in a negative way toward others.
time for one more. So, Mr. Page, could I get you to say a little bit about the issue of accommodating patient requests for a different provider when it's not at one clear end of the continuum or not, how we're dealing with those cases in the middle?
Yeah, so there are a couple of different things that we're dealing with. This idea of a patient preference, where a patient just says, you know, I don't want you because of X, Y, and Z, or I only want someone who is a white male provider or something of that nature, which happens. That patient preference is one that we need to be extraordinarily careful about ever accommodating. And a lot of organizations have gotten into lawsuits, hospitals, because out of the best intentions, they've tried to accommodate these. There's one hospital in Pennsylvania that hung a sign outside the door after receiving a racist request, and it simply said, please see charge nurse before entering. And the charge nurse would say, yes, you can enter, no, you can't, yes, you can, yes, you can, no, you can't, without any other information. And the staff picked up on what was happening. And the hospital lost a pretty serious lawsuit when the staff found out what was going on. The other is this patient-provider concordance. Researchers, in fact, our researchers have shown that there is positive health correlation and adherence done when there is patient-provider concordance of some sort. But also, I'd like for people to understand that patient-provider concordance is not just based on how you were born, but it's your skill as well. So the idea that just because I wear black skin doesn't mean that I understand the African-American experience. I think a great example of this is dermatology, where there's a higher likelihood that someone who has darker complexion melanin may have a specialty within that area, but if someone hasn't studied that at all, and there's a white guy who has really spent all his time studying that, that is going to be the dermatologist that I go to. Now, personally, I go to a black doctor, black dentist, and a black dermatologist. But when I chose those individuals, I researched to figure out who are going to be the right people for me and my family. Now, if a patient comes up and makes a request of you all to say, I only want black docs, should we accommodate or not that list? No, we should not. What I believe we should do is send that patient a list of diverse providers. And if pictures are on there, whatever. But just a list of a whole lot of diverse providers, and let that person choose based on what works for them. They're, especially outpatient, I'm talking outpatient. Who's going to be the best person for them? And then we get to this point where there is a bona fide skill request. The idea that there's been some kind of trauma where someone has been sexually assaulted, or you've got OBGYN or something of that nature, that's a bona fide request that should be. So there are different levels, and we need to be very careful about treating every single request the same.
So I think we're out of time. Thanks to all of you for coming and paying attention, being engaged. Thanks to our panelists.